Thank you, Jared, for that, and thank you for the discount for everybody. I will definitely put
No
that
problem.
on the Learning Academy website for folks that are watching your course in recording. They'll be able to check that out as well. So, great talk. I'm gonna open up the floor to questions. I'm sure Jared has a notebook written already, and I have a few questions, of course. But wanted to open it up to folks in the audience. If you have any questions, why don't you offer them up to Jared? Or Jared Hall, you can just break the ice and get after it.
I mean, I will definitely break the ice. That's, you know me, I usually have about 17,000 questions at the end of these things. First of all, Jared, man, thank you. Excellent presentation. And I'm trying to challenge myself because I was just nodding the entire time you were speaking, and you were hitting me right in all my biases, which is obviously a dangerous game to play. But I really appreciated all of the different resources and references that you presented, because uh, as a lot of people in the group may know, and maybe you know, I'm a lot more familiar with the evidence on the low back and low back pain than I am on the shoulder. I mean, I know a little bit about the shoulder, but bread and butter has kind of been low back stuff. And to see these parallels emerging between the low back and the knee and the shoulder, um, I think that that makes a lot of people feel uncomfortable, but it actually makes me feel more comfortable. It makes me feel comfortable in the fact that there's a lot of complexity and nuance that transcends, you know, the entire body and all of the human pain experience. And it's not just like, well, shoulder pain is massively different than back pain, and back pain is massively different than knee pain. Because I treat a lot of students at university, and I take a lot of students on clinical internships, and they say, well, I kind of know how to manage back pain, but I don't know what to do with somebody with knee pain, or I don't know what to do with somebody with shoulder pain. So I think the fact that you are drawing a lot of these parallels, and finding the commonalities in between, you know, what on the surface seem like, you know, very different conditions is really awesome. And I think that that's super helpful for students. And I was sitting here wishing that like all of my students at university could listen to you talk. So I'm just going to be directing them to your online content. So thanks for that. I really appreciate it. Um, Let me look at my list of questions here. First of all, hat tip on reading some Max Tegmark. Good stuff, really good stuff.
I
Uh,
can't say I understand it all, Jared, but I certainly enjoy listening to it.
oh, I don't understand it either, but I still enjoy listening to it and reminding myself how unintelligent I actually am. Listening to
It's always
people.
good, isn't it? It's always good to be humbled on occasion, isn't it?
And if you like Tegmark, yeah, I don't know if you've heard of him, but Sean Carroll is another
Yeah,
fantastic read. Yeah,
I love
yeah,
his podcast. It's really good.
yeah. So I wanted to ask a specific question, and you got into this a little bit, um, when you said, you know, a lot of times when patients get better, we give them some sort of strengthening exercise, whether it be a low load, higher volume, or a, you know, a higher load, lower volume, or whatever it is, but they seem to get better. But maybe their strength doesn't seem to change all that much. And you specifically said it seems like at max about a 20% strength change in a lot of the studies. Um, I was going to ask if you had any insight or any feeling about why that might be, whether it is, well, could this be a result of, you know, impaired rotator cuff integrity? So they have a small to medium sized cuff tear and they just aren't capable of gaining quite as much strength from the resistance training as a result of that, or if it's more a loading and dosing problem, typically on, you know, the researcher or the clinician's side of things.
Great question. So why aren't they getting stronger? And that is a sort of crucial part of what I'm exploring at the moment. The parameters around prescription is the first place to start. And if you look at all of the clinical trials that sort of prescribe exercise, probably two employ high intensity strength type training, which is, you know, 75-80% of maximum voluntary contraction. The rest of them are your classic 3 sets of 10 twice a day kind of prescription that we're all very familiar with. And we know maybe in sedentary people, that is actually sufficient to increase strength. We have that. Any form of stimulus can increase strength in sedentary people or untrained people, but certainly that's not going to do the trick for trained people. So our strength and conditioning parameters is probably the first thing to look at and point the finger at. And I'm certainly open to a better prescription of strength and conditioning principles resulting in more strength. I'm just not convinced that that's going to result in better results for pain and function. We've got to do the work. We have data, like I alluded to, for knee-OA on that. They get stronger, but it doesn't confer any advantage for pain and disability. We've got to do the work for the shoulder. Other factors that we need to consider, certainly pain inhibition. There's one paper that I think just a simple anesthetic injection into the subacromial space increases strength by 30 or 40% in people with rotator cuff related shoulder pain. So we can't discount an actual central sort of restriction or barrier to that person getting stronger. I'm not convinced it's got anything to do with rotator cuff integrity. Maybe if they've got a huge full thickness retracted rotator cuff tear, perhaps. We certainly have data on partial thickness tears, which shows us that it does not affect strength, and even small to medium full thickness tears as well. So that's not something I think we can consider. I think maybe fear is something we should consider as well. If you think your shoulder is fragile, why the hell are you going to push as hard as you can against a dynamometer if you think that you can break your shoulder by just lifting it up against gravity into the air? So perhaps there's some error there in terms of actually measuring strength and then following it up over a period of time as well. So I think, like anything, it's layered and it depends on a number of different things in terms of why people aren't getting strong. Like the duration is a number thing. We know that durations of studies go for like 6 to 12 weeks. And maybe certain people need to train for 24 weeks or 6 months or a year or what have you. And maybe the volume isn't sufficient. All of these other things. So I think in answer to your question, Jared, it's probably multifactorial, like everything seems to be. And that's cool. That's just the way that it is. But there's things that we can do to actually address that, right? So why aren't we running? And my goal is to run a study for my PhD looking at pure high load, pure low load. What are their changes in strength, and control for everything else? Control for age, control for psychosocial factors, blah, 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 right? And then see what happens and see if it actually is something that we should actually consider more in our exercise prescription.
Man, really good, really comprehensive answer, which led to like 17 more questions on my end that I don't want to cut everybody else. So please, anybody else in the group, if you have a question first, please cut me off and don't let me just talk all night, because I will.
Jared, before you go, can I just say, sorry, just before I forget, adherence to the exercise program is another reason as well. Less than 50% adherence, which is another factor. If people don't do their exercises, it's probably not going to get them stronger.
So that actually leads into one of the questions that I had is, I don't know if you have seen or heard or know if there's any current trial in process on more of a, maybe like a pragmatically applied resistance training protocol where a clinician is allowed to upregulate and downregulate volume, like through an undulating, periodization type process to allow for flare-ups and pain certain days, or days where the person feels strong, or in particular where it seems like a certain person has a greater recovery capacity than maybe other people in the study, whether it be because of their age or whether it be because of other central sensitization type factors, whatever it may be, but some sort of like pragmatic, undulating, auto-regulatory strengthening program that may fit a particular patient better. I didn't know if you had thought about that, seen that, or something like that was going on.
There's a bunch of studies going on. The shoulder's all the rage at the moment. I'd like to precisely match your conditions. No, nothing exactly like that. We have some past data from Chris Littlewood, who's did a paper looking at a self-managed exercise. So this is kind of getting to what you're alluding to there, Jared, where that you do an exercise into a painful direction. So say if someone has a painful arc abduction, classic rotator cuff related shoulder pain presentation, you get a 2 kilo weight and you do lateral raises into that direction, self-managed, self-progressed. So you progress it when it gets too easy over 12 weeks. And they compare just doing that one exercise twice a day versus multimodal physiotherapy, which is throwing the kitchen sink at a patient and hoping something works. And no difference between just doing that one exercise versus a multimodal intervention. So I think that is perhaps fits around a person's lifestyle a little bit more. They change the load as they see fit relative to pain. They progress it as they see fit. So perhaps that answers your question. I don't know if anything that's coming out that really answers it even any better than that.
Well, and, I mean, I'm just spitballing ideas, and I assume that, the idea that I just threw out would be entirely too difficult to design an adequate study for and really track over a long period of time. But that's just, the type of data that I wish that we had.
I will say, Jared, there is one paper has come out from Clausen in 2018, which I'm happy to throw over. So that was more of like a prospective trial, wasn't interventional, so that it wasn't experimental. So can't determine causation or anything, but they showed that people just doing exercise, if they were adherent to their exercise over 6 months, maybe even a year, as much as they can, and they looked at the adherence to actually doing the exercises, that the adherence, funnily enough, made no difference to them getting better or not. So those people who did their exercises over 6 months to a year didn't affect people who didn't. Versus those who didn't do their exercises over 6 months to a year, probably because they got better and didn't see the point of doing the exercises. And also strength changes. So the strength changes between those who got better and those who didn't get better weren't statistically different and were less than 5%. And so that was people just doing their exercises as much as they want, as much as they felt they needed to. And this is a Danish study and Christian Torborg's group put that out. And so that was kind of interesting, where very pragmatic. We can't really just say too much about causation or anything like that, but just leaving it up to people to do their exercises off their own bat, off their own volition, didn't really change movement and mechanical profiles, which kind of indicates my position, but it didn't lead to a worse outcome for them either, which is interesting.
So
in that study, was there actual strength measures done, or did they just do a self-report?
No, they measured strength at base and then at 6 to 12 months follow-up.
6 and 12 months, so they did measure the strength, no change, yep, regardless of whether or not they did anything.
Correct.
So
well, it was a 5% change, so not clinically.
5% difference, right, but negligible change. So it sounds like a lot of central processing just from the general pain then, and then they're able to regulate back to whatever their general strength was. And then we get a middling effect with, because I guarantee you my size at 6'8", 275 is different than a 5'1", 110-pound female, right? But the gains are percentage-wise going to regulate out to make it look like there's a middling effect. But how do we break out and know which ones are going to do what? Or do we even bother, right? And just kind of guide somebody towards what activities they want to be able to do and just have them slowly progress towards those if they so choose.
No, exactly right.
It sounds like it's a central processing process.
Yeah, absolutely. I think everything is a central processing issue at the end of the day. And I think we're just using resisted exercise in order to facilitate some form of recovery. My argument is it doesn't need to be high load. It doesn't need to be strength-based. We don't need to materially change it. We just need to do something that's relevant to that individual, that's probably engaging, progressive in nature, probably. So changing to vary the stimulus, both cognitively and also physiologically as well. Keep it interesting. And I think that's where we're seeing the real benefit of resistance exercise, not simply increasing the force output of a muscle or a movement. I think that's where we are at the moment.
I had a question from the Facebook private feed that I'll share that kind of goes on with what you're just talking about. In your personal experience, do you get better results having patients get back to activities they used to do but couldn't anymore, or having them do things they've never done before and thought they couldn't do in terms of pain and disability?
Do you mean activities or like as the exercise intervention itself?
Not sure, but I think, this kind of activities, like, where you're targeting and kind of integrating things that are things the patient used to do, and you're focusing rehab on kind of familiar activities that were part of their repertoire that no longer are because of this pain issue. Or he's saying, are you having them do things they've never done before and didn't think they could even do in the first place?
I've seen it. I've seen success with both ends of the spectrum and everything in between, to be honest. So I've no personal recipe that I can give to just give people what they've done. I mean, there's a huge push for that, right? That you've got to give somebody some form of exercise that they're comfortable with, that they've had experience with, that perhaps they're not fearful of. But I love predictive processing, and all of that is expectancy violation and prediction errors and doing all of this, right? So I can see the rationale for doing both, to be honest. And I think it's horses for courses and individualized. As always, I know that's a cop-out answer, but I think it's the reality.
Okay, so can I ask a follow-up question to that? In your personal clinical practice, do you have a bias or lean towards choosing a higher load for patients and actually trying to get to that 65, 70, 75% of MPC, or or 1RM, or do you kind of just try to adjust it to what maybe is that person is going to be more adherent with, or some other metric? Do you lean towards the strength, or do you not bind yourself to it and allow yourself to be flexible, since it seems somewhat unclear at this point?
Great question. So it depends. So I see a lot of athletes, and so I need them to get force back to their shoulder, force production. And so for me, if they're not getting that back, I think I'm setting them up for re-injury down the line. So they will end up doing plyometric high load type exercise at the return to sport type phase. For somebody who, for me, I'm getting a lot of psychosocial type vibes off, in terms of they're anxious, they perhaps haven't been very active in their past. There may be some fear around certain movements. They have a very biomedical interpretation of their pain. They think they're flimsy, fallible, and liable to break. Then I'm not going to load that person up heavy. Simply, I'm just going to get them to do a 1 kilo lying on your back pressing exercise, for example. Or I'm not even against using TheraBand external rotation for these people, or a bent over row. All right. So just something low load, high repetition, what I call high control exercise. And then typically I go from more control to chaos over a period of time as that person sort of allows and as their needs demand. But for most people, if I can, I really try and get them back to high force, sort of chaotic type movement, especially if they're young and want their shoulder exposed to a bunch of different forces, if they're going to the gym or playing sport or whatever.
So if I'm hearing you right, it kind of sounds like you get a lot more specific the higher level the person gets, and then the more strength, the more power, the more explosiveness they need, the more likelihood they're going to sustain an injury in the future if they don't have maximum tissue integrity. You get ever increasingly more specific for those type of load exposures, and quote unquote biomechanics become more relevant in those higher performing individuals versus maybe your everyday person off the street that doesn't necessarily have to load their body in that manner and don't have a huge exercise history. You might be a little bit less specific, a little bit more general, a little bit lower load, or finding something that's more palatable for them. Am I hearing you correctly?
100%. And so ascertain goals. Obviously, if I'm seeing a 65-year-old grandfather who wants to lift up his grandson overhead like that, I'm still going to be specific. I'm going to train that movement as well. So there will be some specificity around my exercise prescription, but it's entirely goal oriented. So I'll sort of always reverse engineer, start at the goal, and then try and get that person's shoulder and just them as a human being back to their level of ability that will allow them to participate in what they want.
I'm just curious, Jared, how your physical exams kind of evolved as kind of the research has shown that, some of the things that I think probably you seem about in the same age range as me, that probably things we were kind of drilled into us in PT school. How's that kind of changed as far as your examination evaluation process?
Oh, you have no idea. It's not recognizable from 10 years ago, 5 years ago, even. No, maybe 7 or 8 years ago. Yeah, I'm pretty much just listening to a person talk, and then I test strength, and I know I've just been rubbishing strength, but I test it because I like to prove to them what they can and can't do, right? So if somebody thinks their arm's going to break, I can say, well, show me how much you can push out in external rotation. They can push out 10 newtons, for example. Like, that's strong. Your shoulder is strong and robust. And then the opposite of, if some sort of meathead comes in and is like, oh, I'm strong, I don't need to get stronger. And then I check both sides with a dynamometer, and there's a 20% reduction on one side versus the other. Or they don't have endurance fatigue. They fatigue at 10 reps on one and 15 on the other side. And I'm like, hey, look, you've got some work to do here if you want to achieve symmetry, because symmetry is beauty. So it's changed. I certainly always screen active and passive range of motion. That's non-negotiable. I always look at some form of functional strength testing, and that's usually a scaption raise to fatigue or a side-lying external rotation to fatigue. And I'll test maximal voluntary contraction force as well, just for fun, just to see what happens over a period of time. And then obviously just talking and interacting and saying, well, what do you think's happening when you move your arm in the air, when you have that painful arc? Do you think that's tissue compressing under your acromion? Do you think it's due to a tear? Do you think it's due to something else? And we just sort of have this active interaction where it's almost like a cognitive functional therapy approach, where we're using movement as a way to get that person to understand what they can and can't do at that period of time. So I don't look at the scapula at all, unless it's in an unstable shoulder population where perhaps there is some evidence for it. But I do not look in, I don't even get them to turn around to lift their shoulders up, to lift their arms up in the air. I poke and prod sometimes just to make it seem like I'm a good clinician. I'm like, oh, it's a bit tender there, bit tender there. Yeah, I know what you're talking about. And sometimes it's all a bit of a ceremony, which you've got to do sometimes.
So it sounds like you can employ that cognition targeted exercise that Yones is working his group. But I'm curious, because I think there's this thought that this cognition targeted exercise approach is only for the chronic pain, persistent painers. But I'm curious, in your work with athletes, how much are you still digging into cognitions and their beliefs and thoughts on it? I think that's kind of maybe a misconception that's out there.
Yeah, huge, Mark. They're the worst people for maladaptive beliefs about pain. Trust me, because they're being fed this narrative day in, day out. As soon as you have pain, let's get an MRI. As soon as you have pain, let's inject it. And so their whole philosophy of pain is reductive to the definition. And so they're so hard for me to actually update that person's beliefs about pain. And I'm not saying I can, but I certainly try. Mainly, I try and exert my influence over the team physio or doctor and try and sort of feed them some stuff, and then it trickles down. That's my approach at the moment, because I can't convert everyone. I don't have the time or the energy at the moment. It sounds a bit nihilistic, but
no, that's great. That's fantastic. I'm gonna do one of those things where I put you on the spot, where I'm gonna be that average internet troll and say, well, you gave this presentation and you talked about how, dyskinesis doesn't matter, and you talked about how manual therapy doesn't really affect outcomes, and you talked about how strengthening doesn't really even affect outcomes either. What do you do? What do you do, man? Do you talk to your patient?
I don't know. Be a good person, firstly, listen, do no harm. And then just, I don't know what I honestly, it's conversational. And then I use movement to try and get that person believing in their ability to get better. That's effectively it. And you can use manual therapy. You can use postural correction. You can use dry needling. I'm actually Switzerland when it comes to all that stuff. I'm neutral. I don't give a damn. As long as a person's getting a good outcome and they're not getting taken advantage of financially, then I don't really care what we employ. I think there's many different ways to skin a cat. So anybody can look at the evidence and go, oh, nothing works. I'm going to go and retrain and just be a personal trainer because that's what physios are. Incorrect. I think we have the ambiguity of the evidence shows that we can use everything. We are experts in so many different areas of health. In neuroscience, in psychology, in strength and conditioning, in all of these things, we can use every tool that we can to help an individual sort of get back to what they want to do. So I don't cop the cynical approach. I think we should be skeptical, but that doesn't mean we should be cynical. Being skeptical is just being scientific and looking at things for what it is. But just saying, nothing works is a waste of time. What am I going to do? I think is a misnomer and something we should stop.
No, I love it. And that was a great way to answer that question. I just like to ask that one because
I love it. It's great, Jared. Thank you.
One that I get all the time. Mark, he just put over in the chat bar that he has another question that's come in from Facebook.
Yep.
Yes, Katie asks, how are you explaining it to the patient on what is wrong with them? She put wrong in quotes, and how you plan to help them.
Okay, so firstly, I ask what's wrong with what they think's wrong with them. That's for me the first question, one of the first questions. So a paper came out a year or two ago by Peter O'Sullivan's group, it might have been JP Canero, who sort of listed out a set of questions in order to understand their beliefs about what they think's going on with their pain. And so a lot of it is, what do you think's going on with your pain? And what have you been told is going on with your pain? And what does your imaging mean to you? And all these sorts of things. So firstly, I asked them that. And if they say, well, I've got this rotator cuff tear, so that's what's wrong with me, then we'll have a discussion. And I'll do it gently. I try and be as non-patronizing as possible, which is hard to do sometimes when you've got knowledge that you want to translate, right? So if you want somebody to say, well, hey, tissue damage does not equal pain, how do you do that in a non-patronizing way? It's quite challenging. So often lately, I'm sort of just showing people some data. I've made some graphs actually, which shows that, hey, 60% of people over the age of 50 have rotator cuff tear or have rotator cuff tendinopathy. 98% of people over the age of 50 have some pathoanatomical structure on a scan, be that bursitis, rotator cuff tear, labral pathology, hooked acromion, AC joint degeneration, what have you. So I use those things to kind of just draw attention to the fact that you as an individual are not the sum of your pathoanatomy, and that we have really good data that suggests if you engage in a 12-week rehabilitation regimen, by progressively making it more challenging and exposing your shoulder to potentially painful or pain-provoking positions, that 8 to 9 people out of 10 will have a really good result after that period of time. And so I kind of just so first of all, elucidate what they think. If they come in and go, look, I'm not even that worried about it, I've just got this niggle, I just want you to say that I don't need surgery, then I don't give them the whole spiel about, oh, well, you don't know pain doesn't equal tissue damage, blah, blah, blah. I'm like, yep, you're fine. Keep training, modify some things if you need to, and then come back and see me if there's any issues. So when I'm trying to say what's wrong with people, or trying to give them some form of explanation or validation as to what they're experiencing, I certainly say that, yes, you have pain. I'm not questioning that in any capacity. Validation, super important. And Louis Gifford says that people come to us because they want to know what's wrong with them. But that doesn't mean they must get a pathoanatomical diagnosis or some sort of reductive causal issue to their pain. We can just say pain is a bit tricky. We know that pain comes on due to a number of different factors. What I've tested on you, you might be a little bit weak in those movements. In my head, I'm thinking perhaps that's relevant or not, but there's no harm in trying to get that person a little bit stronger using resistance exercise, all wrapped up in a nice positive education spiel. And that's kind of how I'd go. I never really give someone some causal reason as to why they have pain. I give them a bunch of different hypotheses as to why pain may have emerged. I always discuss lifestyle, sleep habits, and all of these sorts of things as well, which makes it a long consultation, trust me. So it's like I have 1 hour initials. I'm lucky that I can do that. And so I need every minute of that hour as well.
Is an hour-long initial not common in Australia, or is that fairly rare?
No, it's usually 40, 30 minutes maximum, and then follow-ups at 20 minutes barely. So it's like there's no wonder why this model sets up quick needles here, quick manip there, or whatever, because it's hard to talk to somebody and get to the bottom of their issues in a few minutes.
That's really interesting. I guess I take it for granted that I always have 1 hour interrupted for initials and typically 45 minutes to 60 for follow-ups with patients. Wow. That's something that I guess I need to appreciate, more so.
That's a privilege, Jared. That's you're very lucky.
Definitely. So what other questions do you guys have? I have spoken entirely too much in this Q&A session as usual. Crystal, Eric, other Eric, anybody else? Cameron, you guys, Vanessa, have questions? Paul? Mark, I saw you unmute yourself. You look like you're coming in.
No, I was just gonna say, since nobody's asking questions, just to kind of, great talk, by the way, Jared. I've really enjoyed it in the discussion. So it sounds like, because I think sometimes people want like the algorithm or the tool to like elucidate all these like information, but it sounds like, and you correct me if I'm wrong, you get to know the human in front of you and their unique life around what's going on and their unique kind of perspectives versus like some specific battery of like screening tools. Not saying you're not using any of that stuff, of course, but it sounds like you're more focused around really, kind of that person-centered approach to really tailor it to the individual and not this battery of things that every shoulder patient gets. And maybe we can talk about that too. So first off, is that kind of the approach, kind of what I'm hearing and what you do in practice? And then second, are there any things that you find helpful maybe in a triaging process for maybe those folks who are in those unfortunate situations where 30-minute evals and stuff, because we talk to students about that regularly. Is there anything that you find helpful that might can get somebody to maybe some clues to help them when they start getting in the evaluation room to be a little bit more efficient?
Yes. So in answer to your first question, yep, that's how I try and practice as best I can. And I'm probably guilty sometimes of not. And you sometimes revert to saying silly things due to a hangover from my training and all this sort of stuff. And so I try and be as person-centered as I can, and I try and be as evidence-based and blah, 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 blah. But I'm fallible as well. So second point, can you make it more efficient? Well, yeah, like you can. My follow-ups are only half an hour, to be honest. And I could probably get an initial done in 30 minutes and it perhaps a little bit rushed. But the key things you need to bring out for me is asking the person what they think's going on. I know I'm laboring that point, but vital. If you don't have any idea of how they're actually processing or interpreting their own situation, you're going to fail, because you could be providing an intervention that is beautifully evidence-based. And if somebody's thinking something entirely maladaptive at the same time, there's going to be some friction. There's going to be some tension there at some point. So figure out what they think is going on in the first place. Ask them what they think that they need to do. Or have you had experiences with this in the past, or anyone else have had this sort of experience before? Because quite often they'll have known a partner or a family member or something who has had a similar presentation, and then that subconsciously sets up what they should get to manage their condition. So I think having that conversation really early is important, and trying to figure out where their expectations are, because in shoulder pain, the single biggest predictor of a bad outcome of physiotherapy is low expectations of physiotherapy. So that's the highest evidence that we've got. So if somebody has a poor expectation of physiotherapy, whatever physiotherapy is, and I know it's a profession, not an intervention, but whatever they think physiotherapy is, then you need to have a conversation about that early, because if they think that physiotherapy is manual therapy and all they get is exercise, they're not going to get a good outcome. So that's another way to be efficient about sort of matching expectations with the treatment that you're going to provide. And then sort of quickly ruling out sinister pathology or factors afflicting the shoulder that is not due to rotator cuff related shoulder pain. So that's why I always screen passive range of motion. If somebody has a restriction into passive range of motion, I'm going to pursue that, figure out why, because that person will be managed differently to a classic rotator cuff related shoulder pain. I try and figure out their symptom irritability, and that's simple. So that's how severe is your pain, how easy is it to bring on, how long does it last. If somebody has highly irritable symptoms, that dictates how I try and manage that person. I usually don't try and overload that person. I'll just get them moving again without a lot of load and trying to minimize their pain and minimize their fear. If somebody has low irritability, then I try and maximize the amount of load that I put through that shoulder to try and increase its capacity or robustness or resilience, whatever buzzword that you want to use. So for me, that's some sort of, you can do that within 30 minutes easily. Figure out what they think's going on, figure out what their expectations are, rule out a sinister pathology, figure out what their irritability is, and that sets up your management quite nicely.
Thank you, sir.
I think that's super helpful to kind of distill it down and come up with that framework, you know, for everybody listening. So I appreciate you doing that.
No problem.
Yeah, you know, I guess if there are no other questions that want to roll in right now, we'll not waste up any more of your time today. I'm sure that you probably have a lot of things that you need to get done. Maybe spend some time with the son. Maybe you know, work on some research and that sort of thing right now. Jared, I just, you know, we really appreciate you coming on. This was it was really nice to talk about something so clinical and especially specifically the shoulder that, you know, it's such a common pathology. It's such a common presentation that we see every day in clinic. So bringing your expertise in is super helpful. And I think that everybody's going to gain a lot of value from it.
Thank you, guys. Nice to finally meet you. I'm a big fan of all your work, and I listen to your podcast. And so there you go. We're all connected somehow, even though we're in vastly different geographic locations. So yeah, nice to meet you all. Thank you for having me on. Hope I've provided a little bit of value because I am obsessed about the shoulder and trying to figure out how we can optimize our management for people who present to us with shoulder pain. So that's the mission, and I hope I've been mildly successful in living up to that today.
Definitely have, and I want to echo what Jared said, and just thanks for challenging our biases. I think that we love having folks in that. I think there is these kind of movements, and like you said, with the social media gurus and, you know, Instagram vids of millions of ways to load it and all that stuff, to that, you know, maybe we need to pump the brakes and take a more nuanced, person-centered approach. And I thought you demonstrated a great person-centered approach that I think we can all learn from and hope to model ourselves in the clinic. So thank you again for your time. Definitely make sure you check out Jared on Instagram. We'll put his information in the little post here of the video that lives on our learning management system. And definitely check out his course. He's got a solid discount. I would hope that after what you listened to today, that you would think it would be a worthwhile investment to dive deeper with Jared on some stuff around the shoulders. So check that out. But after that, Jared, have a good rest of your day. Thanks for your time. Best to your family. Hope you're enjoying the warm weather there as we're suffering in the Northern Hemisphere in the winter. And we'll hopefully talk to you soon.
Thank you, guys. Cheers. All the best.
Thank you, Jared.